Only 11. Can you just display, Ajay, you have, I mean, who is speaking on what topic today? Shriman is having?
Yes, ma'am, I'm having.
Shriman, can you just show?
Okay, ma'am, just a minute. Can you see the screen, madam?
Yeah. Just a minute. So Dr. Kavita is starting. Yeah, then second, third I am taking. Yeah, thank you.
Welcome, ma'am.
We'll just wait for another few minutes.
Yeah, we will wait. No issues.
Sriman, the last two RAC programs that we had,
Yes, sir.
The exercise that you did for us earlier,
Yes, sir.
in which you took all the participant name and participant city,
Yes, sir.
gave me that feedback of number of societies.
Okay, sir.
Yeah.
Yes,
So
sir. Yes, sir.
last 2 days also you do the same thing.
Okay, sir. I'll do, sir.
And add it to that summary sheet there.
Okay, sir.
Yeah.
So same for the Dheera Obgyn also, right, sir?
No, not the Dheera Obgyn. This is for RAC.
Yes, sir.
RAC, remember, there are 53
Yes,
you are done.
Yes, sir.
And 136 it came to.
Yes, sir. Yes, sir.
Yeah? So same way you do add for these last 3rd June and yesterday's program.
Okay, sir. I'll do, sir. 3rd June is already added, sir. Yesterday program only. I'll do, sir.
3rd June you have added to that list?
Yes, sir. It's there, sir. It's there in the list. 3rd June.
So from 136, has it increased or it is still 136?
It's with include 3rd June, it's 136 societies, sir.
Okay. So tomorrow, today's also, yesterday's also you do it.
Yes, sir. I'll do it, sir.
That list and update that.
Okay, sir. Okay, sir.
Kavita, you're from which institution?
So I'm a private practitioner working in Nasik.
Nasik. Okay.
So I won't be able to share my slides. Is there any scope that somebody can share it?
Why? What happened? I just saw your screen.
And the slide presentation?
I just saw your screen.
I made you co-host, madam.
That was some other presentation which came up.
Madam, I made you co-host now. Can you try once?
Just check. Just a minute.
I think we can start now. Yeah, good afternoon, everyone, or rather good evening. Thank you very much for joining in. We have about 67 registrations for today, and I can see about 11 online. I'm hopeful that as we start, more number of participants can join in who have been part and parcel of this registration to go forward with. Dheera, which essentially means courageous, is a flagship program of our beloved President, Dr. S. Shantakumari, in partnership with UNICEF. And the entire project related to Dheera is anchored on two main pillars. The first pillar is related to the Dheera in schools, in which we are addressing 9 to 12 standard students, girls and boys, and the teachers. And the second arm is related to the obstetricians and gynecologists, all of them who are practicing, may or may not be part of FOXY, but yet are giving services to the women in their respective areas. So that's where the anchoring of the program is. It all began in December 2021. And since then, we have covered about 21,000 students spread across the country, almost 121 schools. We have done about 7 obstetrician and gynecologist program, through which we have addressed 8 critical modules. And these modules which are there, and you will be engaged for the next 2 hours or so, in which we will be talking about the overview of the project, overview of the issue related to violence against women. What are the various aspects related to how to approach a women facing violence? What are the effects on pregnancy and newborn? Mental health issues, and various challenging situations in terms of case studies which will be presented, so that you can understand where we are and what to look out for. What are the various kinds of support and rehabilitation mechanisms? And more importantly, what entails the examination of a survivor and collection of the evidence, because that is another critical part, not just for the women for whom you are doing this, but at the same time, it is also critical for you, because you are also reporting it, and therefore you need to protect yourself also going forward, given the kind of environment that we are in today. And therefore, it becomes critical that you do the process right, the entire documentation right, and the submission of this documentation for further action by the law enforcement authorities going forward. So on that note, we have got our speakers here. We have Kavita, Lakshmi, we have Prema Priya, Gayatri is also here. I can see she has joined in. And the last one is Akila. So we have all these speakers who are joining in, have joined in from various parts of the country, and we'll be walking you through this entire program. On that note, welcome Kavita. We request you to please walk us through the first one. Thereafter, Lakshmi, please take over so that you can walk us through the next 2 topics. Thank you.
So if I can get the screen share, the PowerPoint presentations, I'm not enabled to share it.
Okay. Seeman, can you help, please?
Yes, sir.
What is the issue you're facing, Kavita? You didn't download it.
Yeah, I downloaded it on the other device. It is not getting downloaded on the this laptop.
That's quite odd, because is your net, because I can see your picture and everything very well.
Just a minute, I'll share the slide.
He will share it, but important thing is going forward, because you have another presentation also in the
Yeah.
download and keep it, because it becomes very difficult for us to share it. What happens is, while the session is going on, we in parallel are able to do some other work. But if you are sharing your slides and doing next, we are completely engaged then,
Okay.
Sriman, see if you can do it, please. Thank you. What happened, Sriman? Okay.
Is my screen visible, sir?
Yes.
Yes, we can see it. Thank you.
Yes, sir.
Okay. Thank you so much, Ajay sir, and sorry for the technical glitch. We will begin with our first presentation, the initial introductory session, which is violence against women and overview. And these all slides presentations are done with the help of Dr. Kiran Vinani, Dr. Vindhya T, and Ajay sir. And this is the project Dheera, which is an initiative by Dr. Shanta Kumari, President Foxy. Next. Again, a sincere thank you to all those who helped collaborate on this project by the Dheera team. The contributors for PowerPoint presentation, Dr. Shanta Kumari, Dr. Kiran Mai, Mr. Ajay, Dr. Vindhya, Dr. Ramani Devi, Dr. Rakhi, Dr. Deepa Mukundan, Dr. Anita, Dr. Jyoti, Dr. Rohan, Dr. Krishnendu, and Dr. Aruna. Next. A gender-based violence is the most pervasive yet least visible human right violation in the world. Next. Gender-based violence, we have initially those who have registered must have gone through the pre-test. I request all to answer the questions whichever I read in the chat box. The first one is, what forms of gender-based violence are experienced as women and girls? So you put your comments in the chat box. Where can a woman and girls experience gender-based violence? And the third is, which age groups may experience gender-based violence? Please put your comments in the chat box. We can move to the next slide. So first of all, what do we understand by violence against women? It means any act of gender-based violence that results in or is likely to result in a physical, sexual, psychological harm, suffering to women. These include threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. Next, please. So violence against women encompasses, but it is not limited to only physical, sexual, and psychological violence. It can happen within the family, in the community, or perpetrated or condoned by the state, wherever it occurs. So these are different types and different levels where violence can occur. Next slide, please. So the types can be physical in the form of kicking, biting, slapping, beating, strangling. Psychological violence by preventing a woman from seeing family and friends, belittlement or humiliation, economic restrictions, violence or threat against cherished object, any other forms of controlling behavior. These come under psychological. Sexual violence in the form of forced sex using physical force, threats, intimidation, forced participation in degrading sexual acts, denial of the right to use contraceptives or measures to protect against sexually transmitted diseases. Intentionally inflicted injuries are often disguised as accidents, which we generally see in our practice. At times, women are seriously injured and in some cases die as a result of these injuries. Next slide, please. So the prevalence as per WHO in 2010, it shows in the Southeast Asia, 37.7% of women suffer from gender-based violence. It is shown maximum in the Eastern Mediterranean areas, And in the European, it is 25%, around 25. Western Pacific, it is 24.6. And in America, it is 29.8%. Next slide, please. So the violence, physical or sexual violence by intimate partner in the South Asia is as follows, and which is 28.8% seen in India, which we saw in the previous chart. Next, please. It is seen more in the underdeveloped countries like Bangladesh and Afghanistan, and it is seen relatively lesser number in incidents in the developed countries. Now, this is just the tip of the iceberg. Gender-based violence is underreported. So 40% of the gender-based violence is previously disclosed to someone, but only 7% to a formal source. So regional variation, 2% in India and East Asia to 14% in Latin America and the Caribbean region. Next. The cycle of abuse is seen in all the phases of life. Next. In the pre-birth, we see it in the form of sex-selective abortion and effects of battering or pregnancy and childbirth. Next. In infancy, it is seen as female infanticide, physical, sexual, and psychological abuse. Next. In the girlhood, in the form of child marriage, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, pornography. Next. In adolescence, in the form of children trafficking, honor killings, partner violence, marital rape, dowry abuse, murders, abuse of women with disabilities, rape, sexual harassment, forced prostitution, pornography. Next. Forced pregnancy, acid throwing, date rape, economically coerced sex, incest, sexual abuse in the workplace. It's also seen in this age group. Next. So the 20% of women experience child sexual abuse. You can just keep clicking. And 50% of child marriages occur in South Asia. It is still common in India. Then 125 million women in 29 countries in Africa. And these are especially the female genital mutilation is seen in African women. It is still practiced in this era also. Next. So in Pakistan, in 1957, a woman was killed in the name of honor. So the honor killing is common. It is seen in Pakistan, especially in the 2003 to 2007 period. 11.4 million women trafficked globally, 30% experience intimate partner violence, and 7% sexually assaulted by someone other than partner. Next. So what are the health impacts of gender-based violence on individual? Next, it could be physical or reproductive. In the physical injury, we see in the form of acute physical and the chronic physical. Acute physical, it includes injury, shock, disease, infection, loss, weight loss, regressive behavior, not eating or eating all the time. In chronic physical, it is disability, chronic pain, gastrointestinal disorders, eating disorders, sleep disorders, chronic fatigue. In the reproductive age group, next we see miscarriage. Next slide, please. Miscarriage, unwanted pregnancy, unsafe abortion, sexually transmitted diseases, including HIV, menstrual disorders, pregnancy complications, gynecological disorders. Next. Now, let's see what are the effects beyond the individual survivor. Next. The effects on children of women who suffer or experience the abuse. There is high rate of infant mortality, behavior problems, anxiety, depression, attempted suicide, poor school performance, physical injury or health complaints, experiencing or perpetrating violence as adults. Then what are the effects on families? There can be fractured family relationships, safe care if abuse happened in the home, housing instability, co-occurring violence, poorer collective health and coping. The effect on the community and society are the cost of services incurred by victims and families, whether it is health, social justice, etc. There is loss of education and potential development and contributions by child as they become as an adult, and perpetuation of violence in the community, higher crime rates, burden on safety and justice. Something that which begins in the home, it just percolates in the community, and it kind of becomes a norms, which is a violence going into communities. So here is the Dheera project where we are attempting to stop the spread of the violence and restrict it. Where and how do violence and HIV/AIDS intersect? There can be direct transmission through sexual violence, type of sexual experience, presence of other sexually transmitted diseases, and degree of trauma. Indirect through sexual risk taking, violence is linked to increased risk taking, multiple partners, non-primary partners. And indirect transmission through inability to negotiate condom use, women find it difficult to suggest or insist on condom use in the face of or threat of violence. Next. So the intimate partner violence, the pathways is physical trauma. It can lead to physical trauma. It can lead to psychological trauma or stress and fear and control. So physical trauma can be musculoskeletal, soft tissue injury, genital trauma, others. And mental problems can be post-traumatic stress disorder, anxiety, depression, eating orders, suicidality, substance abuse, alcohol, other drug use, or tobacco. It can also lead to non-communicable diseases in the future, like cardiovascular disease and hypertension. Some diseases can be a somatic or somatoform, which can be in the form of irritable bowel or chronic pain or chronic pelvic pain. Fear and control, this can lead to limited sexual and reproductive control, lack of contraception, unsafe sex. These eventually can lead to perinatal and maternal health issues, low birth weight, prematurity, pregnancy loss. Healthcare, there can be lack of autonomy to take decisions to go and see a doctor, difficulty seeking care and other services. There can be sexual and reproductive health, unwanted pregnancies, abortions, HIV, other sexually transmitted diseases, and gynecological problems. Next. Next, please. So here there is the percentage, 42% of women who have experienced physical or sexual violence at hands of a partner have experienced injuries as a result. Next. There is twice likely to experience mental health issues like depression. Next. Next, please. These women are almost twice likely to have alcohol use or drug use. Next. 16% are more likely to have a low birth weight baby. Next. 15% of the times they can acquire HIV infection or sexually transmitted infection. Next. 1.5%, sorry, 1.5 times. Next. So 38% of all the murders of women globally were reported as being committed by their intimate partner, which is really a shocking figure. Next. 4.5 times as likely to attempt suicide. Next. So let's come to quiz. Now, just state whether this is a myth or a fact. So our first statement is intimate partner violence is more prevalent among poor women and girls. Is it a myth or a fact? Put your answers in the chat box. It's a myth. Studies show that gender-based violence can happen among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends. So it has nothing to do with the poverty or any socioeconomic status. So our next question is, in some instances, especially when it is not severe, beating by a husband can be an effective form of discipline if the wife is acting inappropriately. So what do you think? So the answer is, it's a next slide. It's a myth. Gender-based violence is a serious human rights, health and development issue impacting survivors, their families, and the health and development of entire communities. So next, again, our next question is, majority of the sexual violence against women and girls is perpetrated by the strangers. So what is it, myth or a fact? So answer is, it's a myth. Studies consistently show that most women who experience sexual violence are abused by people they know. Often the perpetrators are those they trust and love. Globally, women homicides are 6 times more likely than men to be committed by an intimate partner. So the next question is it is safer for a woman to leave a relationship with the abuser than to stay? So is it a myth or a fact? So the answer is, it's a myth. Violence often continues and may even increase after a woman leaves her partner. In fact, a woman's risk of being murdered is greatest immediately after separation. Next. So gender-based violence is a serious human right, health and development issue impacting survivors, their families, and the health and development of entire community. So this was about the introductory part of gender-based violence. The registration pre-test has been done. There will be a post-test and a feedback form which you need to submit, and certificate will be awarded at the end. So thank you very much. We can move to the next presentation by Dr. Lakshmi.
Thank you, Kavita. Very good afternoon to all the audience who have logged in. After having an overview of violence against women, I am going to cover 2 topics, that is how to approach these women who are facing this violence and what is the effect of this violence on pregnancy and newborn. So I will be starting with how to approach these women. I hope my slides are visible.
Yes, ma'am, but not full screen.
Yeah. Shriman, this screen sharing is coming in the bottom. Can you take it up?
Madam, you have to do it from your end only, ma'am. I don't have
Okay.
access to that.
Which button?
There's no button, madam. You just move the cursor.
Okay.
Like,
I will manage. Don't worry. Without wasting much time, let me make it slideshow. Where it is. Yeah. So let us start with how to approach these women who are facing violence. But before that, we should understand why these survivors, they are not approaching, they are not asking and seeking any help. Because in general, the perception is that there is in general the victim blaming attitude of the providers. So they think that we will be judging them, we will be blaming them. Then there is a fear of shame and stigma. They are also scared and afraid that their confidentiality will not be maintained by the providers. They are also afraid of the inappropriate services or services that are not useful to the survivor and the perceived impunity of perpetrators. So these are various reasons why these women, they hesitate to approach and to seek help. If at all they decide to seek help, then who can play a role to help the survivors and how can we play a role for them? So who can play a role? Of course, family and friends, community, the service healthcare providers. So there are many who the survivor trust and they can trust and confide in them. They all can offer and they can play a crucial role to support and help these women who have faced violence against women. We have to understand the role of family, friends, and community. Our role, if they seek approach or if they ask for help from us as a family, friend, and community, then remember that the recovery from violence is dependent on the extent of support received from the loved ones. So without judging them, without blaming them, we have to go out, all out, to help and support these victims. As a health professional, we have to engage with family and discuss various ways of promoting the survivor's well-being. It should be discussed with all caregivers that survivor should not be held responsible for the assault. You all have noticed that this sentence is written in bold and in capital, because whether you agree with me or not, this is the general tendency that even as a woman, we also blame the victim that she is somehow responsible. She has gone out late night. She must have irritated her husband. Her husband must have come very tired and she must have put some unreasonable demand. So there are various ways that we only try to blame the victim. Child sexual abuse, parents may experience anger, confusion, guilt, and self-blame. So as a caregiver, as an obstetrician and gynecologist, when we have a chance to interact with these parents whose child has suffered sexual abuse, we have to be empathetic to them. Reiterate that it is the perpetrator who has misused their trust. So by all chance, it is not the victim who should be blamed. Now, what is our role as a healthcare provider? We all know that we are the first point contact for most of the women who come to us for any health related query or inquiry or illness. All women are likely to seek our services at some point in their lives. And as healthcare providers are often trusted by women and they serve as role models in the community. So they do trust us, they do confide in us. Violence is an underlying cause of injury and ill health. This we also have to understand, and we should make the community and family also understand this point. So what is the role of we healthcare providers in creating an enabling atmosphere and establishing the trust with the victim? First and foremost, don't speak to the victim in your open areas or in your reception areas. You have to speak with the survivor in a private space. Recognize her courage in reaching out to you, as they have to overcome so many barriers before she decides that yes, okay, I should go to my doctor, I trust her, I should confide in her. So finally she has gathered all the courage and she has approached you. So recognize her courage. Recognize the dilemma faced by a survivor in reporting violence. Friends, it is really very, very difficult to again go through that violence in the memory and to verbalize the violence which has been inflicted on her. So recognize that dilemma, recognize her trauma. Do not label not reporting to police as a false case, because ultimately you have to respect her choice whether she wants to go to police or not. But yes, she has trust in you, she has approached you, so it is our duty as a healthcare provider to provide her with all the requisite support whichever we can provide. Assure the survivor that treatment will not be compromised by any means. The facilitation and demystification of medical procedures is also very, very important, because we have to prepare the survivor for an internal examination. Just don't order your sister to take the patient, give her a position, and I will come and examine the patient. No. This case is different from your other routine OPD patients. So you have to first prepare her for internal examination. You have to explain her the various stages of examination, right from that she has to undress from waist down, she has to lie down, she has to come and lie on the edge of the your examination table. So each and every step you have to explain her. Communicate the rationale for referral for X-ray, USG, age estimation, amongst others. As I already said, she is different from your other routine OPD patients. So if you need an X-ray or ultrasound or any other investigation, you have to explain to her that why you are asking for that investigation, and when you are referring her, what she will be subjected to. So you have to explain that procedure to her as well. It is your responsibility as a healthcare provider to address the survivor's emotional well-being as well. Recognize that survivor, when she presents to you, she is undergoing varied kind of emotions. Encourage her to express her feelings. Encourage the survivor to seek crisis counseling. Assess for suicidal tendencies. Shriman, please mute everyone. Make a safety assessment and safety plan, and involve family and friends in healing process of the survivor. Remember, it is not your sole responsibility for the well-being of the survivor. Involve family, friends, encourage them to approach the professional counselors for help. What you can say to her? First and foremost, I know time is very, very precious. If you are in public practice, there are too many patients to attend. If you are in private practice, again, time is a big constraint. But these survivors, they do need your extra time. So take out your time, give them extra time, and share only what you would like to share. Your wordings are very, very important. Each and every word has a meaning. So when you are communicating with them, these are certain examples that I can imagine that must have been very hard for you. You take your time, share only what you would like to share. Don't pressurize her to share everything with you. It takes a tremendous amount of strength to share what is happening to you. These are just examples. You can phrase your own sentences. How do you think we can help you as a service provider? Remember, you are not alone. But as I said, you have to be empathetic and sympathetic when you are communicating with the survivors. Give them extra time, give them privacy, assure them of confidentiality. So these are the practical approaches. So when you are consulting and counseling them, do so in a sitting position. It has to be an open posture and not like a closed posture. You should not sit like with your hands closed down. You should lean forward so that she feel that you have given her full attention. Maintain an eye contact and give her that impression that you have full time for her. See to it that your phone does not ring in between. You don't shout to your staff in between. So give her, in short, full time and privacy to this survivor. So this is the main, that listen, inquire, validate, enhance safety, and support. So you can just remember, if you remember the lives, that listen, inquire, validate, enhance safety, and support. This is our responsibility as a healthcare provider when how to approach these women who are facing violence. Listen, listen and listen. We have to be an active listener. If they approach us, use verbal and non-verbal means to show support and communicate understanding. Remember, non-verbal communication also plays a great role. Ask questions which should be open-ended. They should be focused questions. Use good body language, your posture, maintain eye contact. You have to avoid leading questions to them. Don't ask them any leading questions. It is her choice how much she want to confide. Don't ask compounded questions. Learn to listen with not only ears, but learn to listen with your eyes by giving her undivided attention. Listen with your ears by really truly listening to her what she is talking. That is what I am saying, that you have to be an active listener, and listen with your heart. That is with care and respect. You have to listen what she is talking. So there are certain do's and don'ts that for healthcare providers. So how you should act? The do's are, you have to be patient and calm. Tell the client, tell their story at their own pace. Let her know you are listening through verbal and non-verbal cues. For example, you nod your head in between, say maintain gentle and appropriate eye contact. Your attitude, she is noticing your attitude, and you have to acknowledge how she is feeling when she is having a conversation with you. So what you say, you give her the opportunities to say what she wants. You just don't start talking, let her talk. How can we help you? This should be your question to her. Encourage her to keep talking if she wishes. Ask, would you like to tell me more? So these are the do's. What are the don'ts for the healthcare provider? The don'ts are, don't pressure her to tell her story. Don't look at your watch or speak too rapidly to show her that you are in a hurry. Don't answer the telephone or look at a computer, or don't start writing when she is telling her story to you. Don't judge what she has or she has not done, or how she is feeling. Don't say you shouldn't feel that way, or you should feel lucky you survived. I know these are the sentences we loosely use, but we should not use these sentences. Don't assume that you know what is best for her, and don't interrupt when she is talking. Wait until she has finished before you start asking questions to her. Again, in the do's, you have to allow for silence, give her time to think, stay focused on her experience and on offering the support, acknowledge what she wants, and you have to respect her wishes. The don'ts are, don't try to finish her thoughts for her, that is, don't interrupt her, don't end the conversation abruptly, don't tell her about someone else's story or talk out about your own troubles and your own experiences, and don't think and act as if you must solve her problems for her. As I already said, it is not your sole responsibilities to solve all the problems for this survivor. But yes, inquire about the needs and concerns. So how you act? Phrase your questions as invitations to speak. So your questions should be open-ended, where she is encouraged to answer your questions. So ask open-ended questions instead of yes or no questions. Check your understanding by restating what he or she says. Reflect back to the client the feeling they have expressed. Explore as needed. Ask for clarification. If you don't understand, if something she has said and you don't understand, you can definitely ask her for clarification. Help her to identify and express her needs and concerns and sum up what she has expressed to you. In inquire, remember, it is very important what you say. So what you say, these are some examples. What would you like to talk about? How do you feel about that? You mentioned that you feel very frustrated. These are some examples. It sounds as if you are feeling angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything that you need or are concerned about? You seem to be saying that. So have you noticed that all these are open-ended questions, where instead of answering in yes or no, she has to answer you in sentences. Now, validate does not mean to try and verify the survivor's story, for example, through interviewing the alleged perpetrator or witness. This is not safe, appropriate, ethical, or recommended. So remember, this is not what we mean when we say validation. Validate means show that you understand and believe them. Tell them it's not your fault, you are not to be blamed, you did the most important thing you could do in that moment, you survived, help is available, no one deserves to be hit by their partner, you are not alone. Unfortunately, many other faces this problem. What happened has no justification or excuse. Your life, your health, you are of value. Everybody deserves to feel safe at home. I am worried that this may be affecting your health. It's okay to talk. So this is what we mean by validate. Now let us understand the difference between empathy versus sympathy. Because as healthcare provider, we should not cross our boundaries. We have to be empathetic but not sympathetic. So what is sympathy? Sympathy is personal emotional identification with a survivor's experience, and it implies that the service provider is feeling sorry for the survivor. Sympathy is an emotional state that leaves the service provider vulnerable to over-involvement, and it takes away power from the survivor. Sympathy is identifying with the survivor's experience through your own shoes. So I'm sure now I'm clear what we mean by sympathy. What is empathy? Because that is what we all have to be as healthcare provider. Empathy involves intellectual or personal understanding and realistic professional distance. It involves compassion and objectivity, and it leaves room for empowerment of the survivor, and it is the attempt to put oneself in the survivor's shoes. So that is what we are talking about, empathy and sympathy. So dealing with emergency situations during your approach, I have told you about the lives. You all, I hope you all remember. Now, when dealing with a survivor who is in immediate danger, there are certain challenging issues. If the survivor tells you that their abuser has threatened to harm them, what should you do? Put your thoughts in the chat box. If the survivor is telling you that their abuser has threatened to harm them, what should you do? I have shared a few ideas. You can ask concrete questions about the safety risk, but only when there is privacy. Ask if the survivor has a safety plan in place in case she needs to flee. You have to discuss potential strategies for being able to leave her situation safely. Provide a referral to a gender-based violence expert agency for additional help if possible. As a provider, again, I am telling you, it is not your sole responsibility to help out all the issues of the survivor. When a survivor expresses suicidal tendencies, this is another big challenging issue to the healthcare provider. So you should be able to recognize the signs of depression and suicide risk. Do not be afraid to ask, are you having thoughts of suicide? If the answer is yes, take it seriously, very, very seriously. Do not leave the suicidal survivor alone if there is immediate danger to her life. Always consult a supervisor about how to refer or manage a suicidal survivor. This implies when you are in a corporate sector or you are in a public sector. But if you are having your own nursing home, then we alone are responsible and we should take help of our staff in taking care of the suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. Provide a referral to a gender-based violence expert agency for additional help if possible. Nagpur, we have one-stop crisis center. Each and every city, I'm sure, is having that one-stop crisis center. You can all note down the numbers of that center, put it in the reception area, and you can tell your staff to call them, and you can coordinate with those centers about any help which you feel that is needed from this one-stop crisis center. So what should be your behavior? And remember that your behavior has possible consequences. So if you are blaming or disrespecting the survivor, it is inflicting additional emotional distress and trauma on her. If you don't recognize the gender-based violence behind her chronic or recurring conditions, then you are not in a position to provide her appropriate or adequate medical care. If you fail to provide post-trauma, post-rape care, or if you fail to address gender-based violence in family planning settings, in handling the cases of sexually transmitted infections and HIV care, then the consequences are to the tune of unwanted pregnancies, STIs, HIVs, unsafe abortion, and more violence. If you breach privacy or confidentiality, then the partner or family member, they become violent after overhearing the information. So remember, as a healthcare provider, our each and every behavior has a possible consequences. If you ignore the signs of fear or emotional distress, then you are subjecting or making this woman more vulnerable towards later injury, being killed, or she might commit suicide. So your behavior has to be a very, very responsible behavior whenever these survivors, they approach you. The doctor helped me feel better by saying that I don't deserve this treatment, and he helped me to make a plan to leave the house the next time my husband became violent. And I'm sure this is what we all health care provider would want it from our survivors. You may be his excuse, but you are never the reason for his violence. This you have to tell the survivor that you are not to be blamed. You are not responsible for your man's violence. So warm referral practice help women reach further care. Mental health and support system linkages, helpline number should be there in your reception area, because we have to provide them with psychosocial support. We have to provide them with take care of their health. We have to support them and guide her for the legal help if she wishes to approach, and we have to be concerned about her security. So it is a multidisciplinary team approach whenever a survivor approaches a healthcare provider. So friends, post-test and feedback is very, very essential, because you have to earn your certificate. So do these two give post-test and fill the feedback form, and you all will receive the certificate in your email. So now, after telling you how to approach, now let us see why I was discussing in great detail about the approach of healthcare provider towards this survivor, because we all are obstetrician and we all know that violence affects the pregnancy as well as the newborn. This is for you all. Have you ever seen patients in your OPD who have been victims of violence or abuse? Yes or no? You can put your answers in the chat box. How do they present to you? How have you diagnosed? What are the common clinical presentations? And can you recollect a case scene? Whenever we are talking about maternal death, I know we are talking about bleeding, infection, eclampsia, and so many obstetric causes. Remember, 90% of these maternal deaths are avoidable. 50% of these deaths, they occur within 24 hours of the childbirth, and we have to understand the delays which are responsible for these maternal deaths. So what is behind these causes? Because we all see what has been presented to us, that this woman has come with severe bleeding, she has come with injury to the abdomen, she has come to us with APH. But what is the reason behind these obstetric emergencies? This can be a high level of violence during pregnancy can be responsible for some of the obstetric emergencies. Most of the times these women, they don't tell us. He hit me in the belly and made me miscarry 2 babies. I went to the hospital with heavy bleeding and they cleaned me up. So many patients, when they come to us, if you are suspecting violence, do ask them discreetly that is there any violence behind this heavy bleeding per vagina. This is a case study where a primee came with PROM. She presented with prolonged obstructed labor, presented with ruptured uterus. She was in shock and there was a maternal mortality. History revealed later that there was a history of brutal kicking on the abdomen by husband and he pushed her violently, falling and by which she fell on a sharp edge. So this was not a maternal mortality in the true sense. The actual cause of death was violence. This is another case. Gravida 3, para 2, she has 2 living child. This time she is 28 weeks pregnant. She has already history of 2 LSCS. She has come with APH, shock, placenta accreta. Hysterectomy was done. 10 blood transfusions were given. There was bladder involvement. So what you all think? What precipitated this bleeding? So this was the reason behind her APH, and that is husband kicking on her abdomen. So what is the cause of this maternal morbidity? It is not the APH, but again, the violence. Because of this violence, she came to you in APH. This is case study 3. A woman with severe preeclampsia, unconscious, she has come to you with eclampsia with CVA leading to maternal mortality. So what an gynecologist will think that this is maternal mortality due to eclampsia. Is this really so? Actually, this was violence by husband and on postmortem, fractured skull and cerebral hemorrhage were found. So the actual cause of this maternal death was not eclampsia, but violence by the husband. So this was a direct death due to violence. So majority of the times, this hidden violence, it is masquerading as maternal disorder, maternal mortality, or maternal morbidity. This is case study 4. Gravida 3, para 2, 2 living childbirth, 2 previous LSCS, now she is full term. The rod is implanted, she had fractured femur and hip joint. She collapsed in front of a hotel, brought to hospital in active labor with severe hypertension. Emergency LSCS was done, consent was taken by the RMO. So what do you all think? What you are seeing, is this the reason or there is some other hidden violence? This is the reason that she was pushed from second floor 3 years back and now she was abandoned in labor by her husband and by her relatives, and that is why she was brought to you in emergency and the RMO's consent, the cesarean section was done. This is case study 5, gravida 3, para 2, no living child, 2 children's death were there with history of 2 previous LSCS. Now she is 36 weeks, severe anemia. Both times she is giving history of physical violence, kicking on the abdomen brutally by husband, which was followed by loss of fetal movements. Third pregnancy, the parents, they brought her home because they were aware of this history, and this time the LSCS was done and she was rewarded with a live healthy baby. This is again a case study 6. She is gravida 6, para 2, live 2, abortions 3, 2 previous cesarean sections, 3 induced abortions. Now she is in acute hemorrhage, shock, sepsis, and incomplete abortion. So this is a case of severe form of physical, emotional violence. She was subjected to forced abortions and abandonment by her husband. The DV history was that she was brought out only by screening the deep venous thrombosis. She received 4 transfusions and this time she had a healthy baby. So these are all pictures you all can see. This was the stab injury caused by husband because he was inebriated. There was lacerations on the face of the baby, uterus perforation, IUFD, laparotomy was done, rent repair was done. So obstetricians and gynecologists, we are a specialist stakeholder in women's health. We have a unique position as a healthcare provider for these women. It is our responsibility to assess and provide support for women who experience violence because of the nature of patient-physician relationship. So many opportunities for intervention that occur during the course of our interaction with them is that if we are counseling them for adolescent services, if they come to us for antenatal care, if they approach us for family planning services, if they are coming to us for annual preventive self check care, and if they are coming to us for any other health problems. So we get various opportunities to interact with these women. So how to elicit the history? Some indirect questions might be helpful to you. Is everything all right at home? Are you getting on with your partner? We all develop a rapport, a bond with our patients. So just certainly ask them certain indirect questions to inquire whether they are being subjected to any violence or not at home. So these are the screening tools. You have to assess you have to abuse the assessment screen. There is humiliation, afraid, rape. This is the screen. Hurt, insult, threaten, scream. Ongoing abuse, ongoing violence assessment tool. Partner violence tool, partner violence screen. Slapped, thrown, and threatened screen. Woman abuse screen tool, and woman's experience with battering tool. So these are various screening tools. The WHO recommends that all health professionals should be trained in first line response to family violence. And the steps towards this are listen, believe in victim, inquire about her needs, validate the person's experience, enhance safety, and offer ongoing support. So these are very, very basic steps which we as health care provider have to offer. Universal screening or routine inquiry, that is asking all women at all healthcare encounters about intimate partner violence, is not recommended. However, the WHO guidelines identify antenatal care as a setting where routine inquiry could be implemented if providers are well trained on a first line response and minimum requirements are met. So remember, if you are fully equipped, then during antenatal period, you can inquire about intimate partner violence. Ensure safety. The evidence on benefits and potential harms of clinical inquiry and subsequent interventions is lacking or uncertain, because you have to ensure safety of the woman and safety of you and your staff. A minimum condition for healthcare providers to ask women about violence is that it must be safe to do so. That is, you should not ask when partner is present. And that identification of intimate partner violence is followed by an appropriate response. Because just asking has no meaning if she confides you that, yes, okay, I have been subjected to intimate partner violence and you are not able to respond to that, then there is no point in asking her that question in the first place. Detailed guidance on responding to intimate partner violence and sexual violence against women can be found in the 2013 WHO clinical and policy guidelines. You all can go and Google it, download it, and read it. So again, this was in a very, very nutshell that I have briefed you about the approach when you are faced with these survivors, and as a healthcare provider, why we are concerned, because this violence definitely affects the pregnancy and the newborn. So that is why we are concerned. And once again, I am emphasizing that you all have to give post-test and fill the feedback form so that you all can get your certificate. Many women in many parts of the world, they speak the same language, and that is the language of the silence. And it is up to us, obstetricians and gynecologists, to be the voice of this silence victim, provided we are sufficiently trained in taking care of these survivors. Otherwise, don't attempt. So first, be equipped, then ask this history, and if she confides, then you have to act and respond appropriately. So thank you so much for your patient hearing. If there are any questions, you all can post in the chat box and we will answer.
Thank you so much, Lakshmi. It's really been wonderful. And earlier, Kavita, thank you very much, you as well, for walking us through this entire, first 3 sessions. And we will have Kavita come back for sharing and talking to us about the mental health issues. Thank you so much. And please, participants, do share your comments or your feedback or any of your questions you may have in the chat box. We will try to answer or clarify or give some guidance on the same going forward.
So is the PowerPoint visible now?
Yeah, we can see it, Kavita. I'm glad you were able to download now.
Okay, so we had been through the physical health issues, which are, as an obstetrician, we are getting patients in our setup. But many a time it becomes challenging when the mental health issues arise, and we being trained into obstetrics quite lag behind in the psychological or psychiatric aspect. So let's have an overview of the mental health issues, the women who suffer violence. So this is a first case report wherein Mrs. R, 26-year-old woman, was brought to the hospital with complaint of sudden abdominal pain. She was 28 weeks pregnant and married for 1 year, and this was first pregnancy. She was a booked patient on regular antenatal checkup and a non-diabetic, non-hypertensive. On examination, the patient was very much depressed. Vitals were stable, uterus was 28 weeks, irritable, and the fetal heart sounds were normal. Vaginal examination was unremarkable, and on inquiry, she came out with history of being beaten by her husband. What are the details to be gathered from this patient? Whether we need to inform the police, how to counsel the patient, what are the problems that the patient can come across, family counseling, any drugs which can be suggested, and the aftermath of the interpersonal violence, intimate partner violence. So the need of the triad of consultations, the obstetrician, psychologist, psychiatrist, as a team, we have to deal with such patients. Why is mental health support needed? Because as we had seen in the first presentation, there is in the mental health aspect, we have seen post-traumatic stress disorder, depression, anxiety, hypervigilance, mood disorders, substance abuse, sexual disorders, phobia, functional GI symptoms, dissociation symptoms, social withdrawal. These are the symptoms which can be seen in such patient. The first line support is mainly by the obstetrician. So intervention, what is the role of obstetrician? First is risk assessment, frequency, severity, and chronicity, safety from further assault from partner, psychological screening, suicide and danger assessment. Assess the domestic homicide risk. What are the danger signs? Look at the frequency, the number of times the incidents has happened. So presence of severity of injuries, any alcohol misuse, threatening to kill, sexual violence, suicidal ideation in women, access to weapon, or morbid jealousy in partner. When do we hospitalize this patient, especially when she has severe medical injuries? There is a tendency for suicidality or homicidality, dissociative or psychotic symptoms, mood instability, affective dysregulation, self-destructive behaviors are seen, serious threat to patient life. So approach is always a multidisciplinary approach. The treatment plan will be like primary treatment modalities, safety assessment, suicide and danger risk assessment. The myelotherapy, mood stabilization, medication evaluation, psychosocial support, need for rape kit, photo documentation, reporting legal concern. So there is a concept of trauma recovery clinic. So here the objectives are they enable the survivors to come to term with trauma, reclaim lives by reducing the emotional symptoms of trauma, enhancing self-esteem and resilience, improving the social support, prevent re-traumatization, conduct awareness and capacity building programs for psychologists and counselor. So we have such clinics in any multidisciplinary center which is the need of the hour. We can have such clinics. And for example, this was in 2014 at NIMHANS. So what are the psychosocial impact? The woman may feel helpless. Progressive erosion of confidence and self-esteem can be caused by abuse. Feeling of guilt, shame, isolation, traumatic bonding paradoxically strengthen the emotional ties to perpetrators. Physical separation due to increased risk of homicide and decreases the coping ability in victims. What is the role of psychologist? It plays a major role in the treatment. There is a post-assault psychotherapy, cognitive behavior therapy, exposure therapy. Variant to CBT is it helps the victim to emotionally process the assault by decreasing fear to memories or cues of event. A brief trauma-focused CBT. So there is a STAIR approach or the skill training in affective and interpersonal regulation. Herein, there is a psycho education about the impact of trauma on emotion and relationships, emotion regulation skills, effective expression of negative emotion, interpersonal skill related to appropriate assertiveness, development of flexibility in regard to interpersonal expectation, actions, and reaction. Treatment also includes recognition of achievements during treatment and exercises in self-compassion. So interpersonal psychotherapy, it has shown to be an effective non-exposure based treatment in post-traumatic stress disorder. Many post-traumatic stress disorder symptoms reflect interpersonal difficulties such as emotional withdrawal from relationships and individuals, interpersonal deficits, persistent loneliness, sometimes resulting in interpersonal hypervigilance. So the IPT, other new psychotherapies include cognitive processing therapy, CPT, eye movement desensitization reprocessing. HOPE is helping to overcome PTSD through empowerment, relapse prevention, and relationship safety. So these terms may become difficult for as an obstetrician. Of course, this is a multidisciplinary, it's a team effort. So what are the psychological therapy? Women experiencing IPV related depressive disorder or alcohol disorder should receive mental health care as per Mental Health Gap Action Program Intervention Guide 2010, delivered by healthcare professionals with good understanding of CBT and EMDR intervention delivered by healthcare professionals with good understanding of war are recommended for women who are no longer experiencing violence after suffering from PTSD. So the WHO recommendation for depression and other emotionally or medically unexplained complaints, there is a role of antidepressant and benzodiazepine. In mild and initial phase, there is no need for treatment. Moderate to severe case, TC or fluoxetine can be prescribed. If absence of prior depressive episode, no need of drug in the initial phase. The duration of treatment can continue as long as 9 to 12 months after recovery. There is a brief structured psychological intervention, interpersonal therapy, CBT, and behavioral activation and problem solving treatment. The relaxation training and physical activities also taught. Psychological support after recent traumatic event, psychological debriefing, psychological first aid, acute distress. So men also need treatment. Here we are talking all on women, how we diagnose, how we treat. Equally, men have to undergo therapy. So a men group treatment therapy wherein encouraging men to take personal responsibilities for violent behavior, challenge attitudes on belief around the use of violence in relationship, developing skills for reacting non-violently to others, increase the awareness of dynamics involved in use of violence. So in conclusion, mental health is an issue in war-affected women and thus needs to be addressed along with the physical health. So thank you so much for providing us with these excellent slides. They themselves are so self-explanatory. We have a post-test after every lecture. We are announcing that you have to take a post-test to get the certificate. Thank you so much. Thank you, Ajay sir.
Thank you, ma'am. Shriman sir, can you allow me to share the screen for the next module?
Yes, madam. Kaja madam, can you please stop share the screen? Made you co-host, right? Madam, you try once, ma'am. I made you co-host.
Okay, sir, sure. Is my screen visible, sir?
Yes, madam.
Yeah, we can see it.
Okay. So coming to the challenging situations in war and self-care. Not able to move the screen. Okay, sir. So coming to the challenging issues, when dealing with a survivor who may be feeling hopelessness, having suicidal thoughts, or in harms in any way. So what would you do? Here is an example. You're a gynecologist and one of your patients in your clinic tells you she's being threatened by her mother-in-law, who is constantly pressurizing that she must divorce her husband because she's unable to have children. She feels hopeless and wants to give up. What would you do? You do nothing, or would you do something? Please put your inputs in the chat box. So here are a few ideas. Be able to recognize the signs of depression and the risk of suicidal tendency in the woman. Do not be afraid to ask, are you having thoughts of suicide? If the answer is yes, then take it seriously. Do not leave the suicidal survivor alone if there is immediate danger. Always consult a supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. Provide a referral to your gender-based violence expert agency, that is One Stop Crisis Center, for additional help if possible. Obgyn should not ask survivors about suicidal thoughts or attempts. It could encourage suicidal attempts. Is it true or false? Please put your answers in the chat box. So it's actually false. Asking about suicidal attempts or thoughts does not increase suicide attempts. On the contrary, talking about suicide often reduces the woman's anxiety and helps her to feel understand. If the survivor tells you that their abuser has threatened to harm them, what should you do? Please put your inputs in the chat box. So here are some few ideas. Ask concrete questions about safety risk, but only when there is privacy. Ask if the survivor has a safety plan in case she needs to flee. Discuss the potential strategies for being able to leave her situation safely, and provide a referral to gender-based violence expert agency for additional help if possible. So one of the most helpful techniques for helping a survivor to get out of an overly emotional state is to ask them closed-ended questions that require them to think. It actually shifts them from an emotional state to a cognitive, that is thinking state. Should request short answers and do not return to open-ended questions unless the survivor feels comfortable and has some degree of emotional control. Here are some examples of close-ended questions that you might ask. Like, how many kids do you have? She may answer 1 or 2. Are they going to school? And what are their ages? So they'll try to come out from the emotions and start answering your questions. Then ask about the open-ended questions. So coming to the challenging issues when dealing with a survivor who may be mentally ill. State clearly who you are and what is your role. Always be empathetic. Be non-threatening and sincere in your attention to help. Give honest and factual answers whenever necessary. If you do not know, say so. Do not belittle concerns which the survivor raises. Do not give advice as to handling of their psychological problems. Attempt to be supportive in comments and gestures. Do not assume mentally ill people should know better, or on the other hand, that they need to be told what to do so. Be careful about making any assumptions. Know how to activate emergency mental health backup. So coming to the additional challenging issue, that is mediation. What do you think? Can we be a part of mediation process? So remember, mediation is not recommended as a response to gender-based violence. Healthcare workers are a part of survivor-centered referral mechanism. The mediation process itself maintains and contributes to the abuser's ongoing power and control over the survivor. The process of mediation presumes that both parties can speak freely, confidentially, and safely. But that is not that ease. Mediation rarely results in an end to abuser's violence, but actually it leads to an increase in violence. It is unlikely that the survivor's rights will be respected. Coming to the core safety precautions when dealing with these challenging issues. As Lakshmi mentioned, always, you does not mean your sole responsibility. Multiple people can handle difficulty better and more effectively than one person. A service provider should never feel like he or she must work alone with the survivor. Always remember that the service provider should not work both with the perpetrator and the survivor, neither separately nor in the same interview. Keep the office door open of leaving the office or home if feeling unsafe. Try to establish a code word with co-workers to identify the unsafe situations. Establish the relationship with the local police or the security team. Use buddy system at work and to and fro from work and if doing home visits. Use supervision to address security concerns. A group of people can address the security more effectively than an individual. Coming to the self-care for the healthcare provider. It is critical for you. Do you know what is vicarious trauma? Please put your comments in the chat box. As a service provider, you should be aware of it for the self-care. So vicarious trauma is a change in the service provider's inner experience as a result of emotional engagement with the survivors of trauma and hearing their stories. Changes that occur in the service provider's physical, emotional, and or behavioral states as a result of constant exposure to the traumatic stories or events. So the causes are mainly because of the constant exposure to the stories of trauma, desiring to help or change the survivor situation, feeling powerless when a service provider does not see positive change in the survivor situations, overly identifying with the survivors, thinking that the service provider has a power to change your survivor situation. So, what are the preventing and managing situations in the vicarious trauma? Here comes the ABCs. A is the awareness, being attentive to one's needs, limits, emotions, and resources. Practice self-acceptance. Maintain balance among the activities, especially work, play, and rest. Maintain supportive relationships. Communication is a part of connection and breaks the silence of unacknowledged pain. These connections help prevent the isolation and increase the validation and hope. Here are some self-care for the healthcare provider. Create boundaries in the workplace, establish support within the work environment, seek assistance from the outside agencies, and create our own self-care plans and follow them through. And here is a quiz. And these are the statements which you had seen in the second module of Lakshmi ma'am's. So please put your comments in the chat box whether the statement 1 is mentioning about the sympathy or empathy, and statement 2 is mentioning about sympathy or empathy. So sympathy is a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. It is identifying with the survivor's experience through our own shoes. Empathy is what needed, and it implies intellectual or personal understanding and realistic or professional distance. It is learning to create boundaries. It involves compassion and objectivity and leaves room for empowerment of the survivor. It is an attempt to put oneself in the survivor's shoes. So, how do you take care of yourself? Please put your comments in the chat box. You can use some relaxation and self-care techniques. So please fill the post-test and feedback form for getting the certificates. Let's move on to the next module. Is the slides visible, sir? Shall I continue?
Yes, madam.
Okay. So the next is the most awaited one. What are the support system and resources for the survivors? So in this section, we are going to see what are the protective laws and acts, what are the helplines, and what is OSCC, that is One Stop Crisis Center. How can we link up and help in the rehabilitation of the survivors? So this is called as a Protection of Women from Domestic Violence Act 2005. It extends to all of India except state of Jammu and Kashmir. So initially in 1983, Indian Penal Code 498A was there. But why this act came? Because 498A has no emergency relief available to the victim. The remedies available were linked to the matrimonial proceedings, and the court proceedings were always protected, during which the victim was invariably at the mercy of the abuser. Relationship outside marriage were not recognized in 498A. So Domestic Violence Act 2005 is a civilian law. In this, the female or wife can get relief, but there is no punishment or arrest unless the husband violates a court's order. Another difference is that 498A can be booked against husband or his relatives, but Domestic Violence Act can be booked only against the male members of the family. So who can be a complaint? It could be a wife or a woman based on the consanguinity, marriage, adoption, or cohabitation against a male abuser in a shared household. A woman who is in a relationship similar to the marriage with a man, technically a transgender male to female, could bring an action against a transgender female to male. A woman in a relevant relationship with an unmarried man, but not a man who is married if she knew or ought to have known that he was married. Anyone can file the petition with the survivor's consent. Please remember, the petition should be filed only with the survivor's consent. So, whom can be, this complaint can be given? It can be given to the protection officer, service providing center, medical officer in charge, police station, or the magistrate. So, where it can be, complaint can be registered. It can be given in the jurisdiction under the Protection of Women from Domestic Violence Act, where the wife permanently or temporarily resides or carries on her business or employed, or the husband permanently or temporarily resides or carries on his business or employed, or that the cause of action or violence has arisen. The wife can choose any of these three options. So what are the types of orders? It could be protection orders, stop violence, emergency relief, can request separate housing and abuser, must provide the shelter orders, custody order, compensation orders. Violation of any of these above orders is an offense and magistrate may charge for this offense. Under the section 31, non-compliance of a protection order by the magistrate can lead to issuance of non-bailable warrant. So what's the time prescribed? The Act requires that all the proceedings should be disposed of within 60 days, 60 days of the first hearing, with which it must occur within 3 days following the application. So what are the services offered? The service offered includes filing a detailed investigation report, complaint to a shelter, facilitating free legal services, and providing counseling services as required. So these are the domestic legal remedies available in India. Article 14, mainly the Constitution of India deals on the equality. Then Act 1990 deals with National Commission Act for Women, Dowry Prohibition Act, 498 IPC, and Protection of Women from Domestic Violence Act 2005. Coming to the concept of one-stop crisis center. It is mainly to provide immediate medical, legal, and psychological needs of women who are the survivors of abuse, could be a physical abuse or mental abuse, with an assurance that their consent and confidentiality will be respected and protected. At present, in India, 234 one-stop crisis centers are there all over. These are also called Shakti centers. However, the first one is started in June 2014 in Madhya Pradesh. It's a Gauravi. The Gauravi staff of 10 focus on the victim's needs without compartmentalizing the services. And it's mainly a joint initiative of Department of Public Health and Family Welfare and Government of Madhya Pradesh. And this is the Bharosa Trust and she teams. They started in Hyderabad with the Honorable President Dr. Shantakumari ma'am. A woman can walk in with the assurance that her consent and confidentiality will be respected and protected. In this, everything is provided in, all services are provided in one place, such as police security, counselors, psychologists, legal advisors, medical help for the woman who suffered from violence. The helpline is 100 and it will be directed to the Bharosa Center if it is violence. Coming to the one-stop crisis center. The one-stop crisis center is mainly intended to support women affected by violence. It could be a physical, emotional, or sexual, or psychological, or economic abuse, irrespective of age, caste, education, race, etc. And the main aim is to provide integrated support and assistance to women affected by violence, to provide either immediate or emergency or non-emergency services, which includes medical treatment, forensic DNA testing, police assistance, legal support, social welfare services, psychosocial counseling, rehabilitation, custody shelter home, and social integration. And these are some of the helplines. So All India Women Helpline is 1091. Women's Domestic Abuse Helpline is 181. Remember that POXO is 1081 and for women in distress, All India Women Helpline is 1091. And these are the helplines available in Delhi. You can take the screenshot of these helplines. And these are the helplines available for Andhra Pradesh, Arunachal Pradesh, Andaman Nicobar Islands, Bihar. You can take the screenshot of these and you can share in your local societies or your friends so that it can help somebody who is in need.
Prema, what we can do is we can move fast with this portion.
Okay, sir.
And we will, can just flash them. And we will be sharing a copy of this PPT with everyone here. So that will help, individuals who are looking for these numbers.
Sure, sir.
Yeah?
Sure, sir. So these are for union territories. And these are for Gujarat, Himachal Pradesh, Jharkhand, Jammu, Karnataka, Kerala states. And these are mainly for the Northeast, Meghalaya, Mizoram, Nagaland, helpline numbers. And somebody in the group has, sir, for Pondicherry, the helpline is 181. Then Chandigarh, Rajasthan. And this is for Tamil Nadu, Telangana, Tripura, Uttar Pradesh. And this is for West Bengal. We'll share you these helpline numbers. Thank you all. So at the end of the overall session, you'll be given the post-test and feedback. Kindly fill in those for getting the certificates. Thank you for your patient listening.
Thank you so much, Prema Priya. Wonderful job done. And we're meeting back to back yesterday and today.
Yes, sir. Thank you, sir.
With that, I think
Stop sharing. Yes, I think next is Dr. Gayatri, sir.
Thank you, Dr. Prema Priya. That was exhaustive and a lot of your input also. With this, can I share my screen?
Yes, ma'am. Thank you, ma'am.
Yeah.
Yeah. Welcome, Gayatri.
Yeah, thank you, Mr. Ajay. So, is my screen visible? Am I audible enough?
Yes, please. Screen is visible, audible.
Enough. So
Make it full screen, ma'am.
Make it full screen.
Yeah. Is that visible?
Yes.
At the outset, I'd like to really show my appreciation to the Team Foxy 2022 for taking up such a very unique and a very day-to-day what we face, but it's very little addressed, this violence against women. And when we talk about violence against women, the lay person, the first thing it strikes, especially after reading today's newspaper and other things, more than what is the domestic violence, is the first thing that strikes our mind is sexual violence. And as gynecologists, we are the people who are going to be facing these people day in and day out. Yes, I understand that the people in the government setup are going to be much more, involved in facing these, but the private practitioners should also know what are the very important things in sexual violence. So how do we approach a person who is said to have been a victim to sexual violence? So for that, we should know how it is defined. So sexual violence refers to any sexual act or attempt to obtain any sexual act or unwanted sexual comment, and acts to traffic against the acts to traffic that are directed against a person's sexuality using coercion by anyone, regardless of their relationship to the victim, in any sitting, including at home or at work. Here, to put it in a nutshell, it is not just a penetration which is without a consent or other things, even comments in the public by anybody known to us or not known to us, in any place, whether it is our home, at school, at college, at work, or just any shopping or public place, anything which damages our sexuality, which harms our sexuality, is said to be sexual violence. Rape is not only, all rape is sexual violence, but all sexual violence is not rape. Even comments and other things will fall into sexual violence. So rape is a term that is commonly used for the first type of sexual violence mentioned. WHO's definition of sexual violence includes, but is not limited to rape. As I already told, all rape is sexual violence, but all sexual violence is not necessarily rape. Rape, you call it when there is actual penetration of the vulva or the vagina or any other part of a woman, whereas a sexual violence includes even exhibitionism, any other kind of comments made in public, eve teasing, everything. So there are some facts about sexual violence that we have to know, especially the public also has to be sensitized about this, and as healthcare providers we should be knowing. The chances are that someone that you know someone who's been sexually assaulted, because that is so common and very little spoken about.
Victims usually know their assaulters. Victims are never at fault for a sexual assault. So in India, we usually have this problem where when there is a victim, we always try to say it is her fault, she should not have gone out now, then, etc. That is never true. Rape is the least reported and convicted violent crimes in the world. And sexual violence is preventable when it is properly, when we empower the gender very properly. Help is available. And rape can be in a lot of circumstances. It can be within a marriage or dating relationship. It can be somebody whom you are intimately related to. A rape is any kind of a sexual advancement without consent. It can be by strangers. It can be a systematic rape during armed conflicts, unwanted sexual advancements, and sexual harassment, including demanding sex in return of favors, where there may be a consent following coercion and other things. Sexual abuse of mentally or physically disabled people and sexual abuse of children. Forced marriage or cohabitation, including child marriage. Deny the right of contraception or any other method to protect against pregnancy or any other sexually transmitted disease. Forced abortion is a sexual violence. Violence against the sexual integrity of a woman, including female genital mutilation and obligatory inspection for the sake of establishing somebody's virginity. Forced prostitution and human trafficking, all these things. Out of these, I think the denial of rights to contraception and forced abortion we see day in and day out. Marriage is often used to legitimize a range of forms of sexual violence against women. And marrying of young children, girls, are very common in many parts of the world. And it's very common in India, especially in the rural place. In many places, it is legal. And children involved are unable to give or withhold their consent because they never know what it is about. Majority of these children who get married, they do not know anything about sex before they are actually subjected to it. So they do not even know whether to give their consent or withhold it. So the consequences of sexual violence include pregnancy, unwanted pregnancies, teen pregnancies, gynecological complications, which include sexually transmitted diseases, mental health issues, fears, anxiety, depression, suicidal behaviors, and social ostracization. The more fatal outcomes will include suicidal tendencies, homicidal tendencies, and the more fatal sexually related diseases like AIDS. The other kind of outcomes which are non-fatal but very disturbing are unwanted pregnancies, infertility, sexual dysfunction, chronic pelvic pain because of PID and STDs, sexually transmitted infection, including the AIDS range of infections, obesity and anorexia, which is again a psychological manifestation, urinary tract infections, gastrointestinal disorders, gynecological and pregnancy complications, other migraine, cluster headache, tension headache, fatigue, nausea, and the psychological consequences will include the rape trauma syndrome, post-traumatic stress disorder, social phobias, a shock, psychological shock, where they get into alcoholism or any other substance abuse, denial, fear, anxiety, confusion, and guilt, which is imposed by the society, depression, alienation, and eating disorders. All these things are the psychological consequences of sexual violence. Sexual assault. Now let's see how we are going to approach a person, a survivor of a sexual assault. This is the most invasive and intimate form of violence. A trauma-informed care approach should be utilized. This should involve an understanding of the neurological, biological, psychological trauma that she's undergone. So when a patient presents and reports a sexual assault, we should look at her as a medical emergency and we should not allow her to wait among all the other OPDs. This is a medical emergency in triage. The immediate needs of the survivors of a sexual assault should be addressed, and they are medical and psychiatric evaluation, and stabilization. Comfort her, tell her it's okay and it's okay to talk about it, and she can feel safe and confidential in our setting. Activation of community advocacy to the bedside. Reporting as directed by the state legal structure, state statutes. Offering and conducting a sexual assault forensic examination, which is called SAFE, the sexual assault forensic examination, which will be dealt in detail in the next talk. Collaboration with the law enforcement. It is our duty to inform the law enforcement department, and which is only if desired by the survivor. We should not force her. By doing it, we will make her go into further depression or anxiety. Just make her first comfortable, ask her if she wants to launch a complaint, and prophylactic medications for any diseases that she might encounter, any emergency contraception, risk of pregnancy, and devise a safe discharge plan for her. Those providing these care must always be prepared to provide these facts in case we are called as an expert testimony in the court of law. So application of this trauma-informed care to a patient will involve these things. She should feel safe and we should be trustworthy. She should disclose whatever she wants to by choice, and we should be working in collaboration with the other parts of law. And with this, it is not over. We should tell her that this is not the end of anything, and we should take equal interest in empowering her for the future. So what are the things that we need to handle when we approach these girls? First, basic, knock the door, ask her permission. We do not know what kind of psychological state she is. So knock, ask her permission before we enter the room. Meet the parents, ask to disrobe only if it is necessary for some kind of examination, and ask her if she is willing to do that. Provide her and clearly identify that she's got washrooms, she can feel safe. Take time to establish a rapport with her, talk to her, give her a comfortable level of lighting, share control, show respect, tell her that you are not here to judge her. Explain all the procedures that she is likely to undergo in a language that she would understand. And if she doesn't understand and you are able to see it on her face, please ask her to ask questions and make sure she's comfortable before you go in for any procedure. Tell her what to expect, whether it will pain, it will not pain, how long it will take, and tell her she can refuse any examination if she does not want it. Ask her every time you're going to do an additional procedure or additional test, or even to touch her, take a consent, verbal consent each time. Ask her if she's okay. If she wants a minute more, you can give her. Allow the person to decide where she wants to sit in the room. Ask her to explain her, explain when you want to examine her. Take consent for each part and tell her why we want it done. We don't want to re-traumatize her. So she should know what is being done, why it is being done, and why. She can, even after knowing everything, she can by choice deny the procedure or examination. And in that case, we need to just document it and not force her into it. And ask her what are her top worries and concerns about the whole incidents. And first, we should try to address it, whether she wants to take it up in the legal way or she doesn't want it. And we have to give importance and respect it. Encourage the person to make decisions about her own information and tell her we will share information only if she would permit us to. And assure her that whatever happened, ask her what happened to you, not what is wrong with you. Don't treat her like she's a patient. And never ask the question why, because it usually implies fault and will impose a lot of guilt on her. We can take time with the person so that she feels genuinely heard. We need not be in a hurry. To handle these patients, we should never have time as a constraint. And we should ask the person if she's got a preference or has any difficulty with any particular procedure. And we should ask the person what you should know before to begin the procedure. Always ask if there is a way you can make the procedure easier for them, whether they want to sit in a different position, lie down in a different position, and pay attention to the body cues. Many survivors have been conditioned to be passive and to defer to authorities and not to disclose any distress during a procedure, which is not the right way. So give her enough comfort so that she tells us what she feels like. And in the sexual assault history, these are the very important ones. I would like to mention them, and these will be very detailed. They'll be dealt with in the next speech. The medical history. We should ask her whether she's been sexually active before the assault. Assault-related medical history and details of the assault. Nature of any physical assault. Post-assault activities, whether she's passed urine, motion, etc. And any suspect information. And thank you very much, organizers, for giving me this wonderful opportunity. And the registration and pretest, I hope it has been done by all the participants. Post-ins and feedback is mandatory for us to get our certificates. Thank you very much.
Thank you. Gayatri, thank you so much. That was wonderfully done and taken forward.
Thank you.
We have
Good evening.
the next.
Video.
Yeah. Akhila, are you there?
Yes, sir.
Oh, very good. Okay, great. So over to you and all the very best. Thank you so much.
Dr. Akila, we can see you.
Okay. Thank you. Can you see the slides?
Yeah,
Yes,
we
we
can see it. You need to make it full screen.
Yes. Examination of a survivor and collection of evidence. The role of a gynecologist in this is very important, as they have to collect the evidence of the crime. It helps the judges to understand the physical and mental condition of the survivor. We have to report the survivor's story and the credibility of the story, and offer the primary level counseling and treatment and referral for the physical and psychological sequelae of the survivor. This medical examination has to be done. It has four important parts in it. We have recording of the history is very important. An informed consent should be taken, and documentation of any injuries, and evidence collection, nature of the sexual violence, time elapsed between the incidents and examination, whether the survivor has bathed or washed, everything has to be documented and informed. We have to remember about 25 things in this. The first is general instructions. That is, in the first few we'll have to know the name of the hospital, patient's IP number, OP number, patient's name, address, everything has to be written down. All these 11 points with the patient's address, age of the patient as reported, date of birth, sex of the patient, date and time of arrival at the hospital, when did they come, when did you start your examination, who brought the patient to us, who brought the patient to us. If it has to be registered, then medical legal number, and to which police station it has to be informed. Whether the patient was brought to you conscious, if she's oriented, if they are oriented to time and place, should be known. If there is any, if the patient is physically challenged or psychological, if there is anything, then we'll have to take the language barriers there, then we'll have to put on all the, we have to arrange for a translator, and we have to have them with us. And next would be a informed consent. This is a very important thing, because they have to give us a consent for examination. They can even refuse. So we'll have to get a consent saying that if we have to get an informed consent for our medical examination, for medical legal examination, sample collection and forensic examination. They have to understand that as per the law, the hospital requires to inform the police, and this has to be explained to them. They have to say, and I want the information to be revealed to the police or not. We can ask them if it has to be revealed or not. If yes or no, they have to give. I understand the purpose and procedure of the examination, including the risk and benefit, explained to me by the examining doctor. My right to refuse the examination at any stage. They have the right to refuse the examination. and the consequence of such refusal, including that my medical treatment will not be affected because of my refusal. You have to arrange for a special educator or an interpreter if they have to, and their sign is also very important. And marks of identification for the patient, if there is any scar or mole, and left thumb impression have to be taken. Relevant medical and surgical history, onset of menarche in case of girls, and age of onset of menarche has to be taken. The menstrual history has to be taken. Last period's date, menstruation at the time of the incident, if she was menstruating or not. Was the survivor pregnant at the time of the incident? If pregnant, then what weeks? Contraception was used and vaccinated. If she's vaccinated for tetanus and hepatitis B. Date, then history of sexual violence. From here, the date and time or when she reported. Time of the incident is very important. Location and estimated duration, how many days, after how much days she's reporting to us. Episodes, how many episodes was she sexually assaulted, number of assaultants, name, sex of the assailants, approximate age of the assailtant to be noted. If it's a known relationship, then they can if known the relationship to the survivor. If it's a known person, we have to need to write down what relationship they are. Description of the incidents in word has to be narrated, and you can narrate the incident as per the survivor or the informant, whoever gives you. And then if necessary, you can take more history and add extra things. Injury, type of injury to be noted. What type of injury it is? Was it hit with a hand, fist, blunt injury, or it's a sharp injury, biting, pinching? What type of injury? Or burnt with kicking, pulling your hair, anything, whatever type of injury has to be recorded. If it was an emotional abuse, emotionally was the patient tortured, emotional abuse or violence, if any, or use of any restraint, if any, use or threatened, the use of weapon or object, verbal threat, for example, that they threaten to killing or hurting the survivor. If they say anything, or any other person, if they have photographs, if they are blackmailing, where they lured using chocolates, drinks, alcohols, or anything, that has to be found out. Then if the patient was conscious, that's what, if any history of alcohol or drug intoxication was there, whether sleeping or unconscious at the time of incident has to be noted down. If the survivor has left any mark or injury on the assailtant, then it has to be noted down. Details regarding sexual violence. Was a penetration of the penis, finger, or object or any other body has to be mentioned. Which organ was involved? Where was the penetration? All these has to be, if there is where ejaculation was there, yes or no. If they could identify it, we have to note down everything, and we have to ask them regarding all this. It has to be noted down. Details regarding the sexual violence. That's what, if it is oral sex, or forced masturbation of self by the survivor, forced masturbation of the assailtant by the survivor, forced manipulation of the genitalia has to be noted. If it is exhibitionism, did the ejaculation occur inside or outside the body orifice? If yes, where on the body? Was the condoms used? If they could tell us yes or no. Lubricant was used. If anything, describe what type of lubricant. It has to be done. So post incidents, if they had, we'll have to note down if there is any history of vaginal, oral, or anal bleeding was there, or discharge was there prior to the instance of sexual violence. If there is any history of vaginal, anal, or oral discharge since the instance of sexual violence, was all the discharge prior or afterwards, we have to find out. There is any painful urination, painful defecation, fissures, abdominal pain, pain in the genitalia, or any other part of the body since the instance or sexual violence has to be noted. If anything, so here it is all very important. We have to note down all the survivor has changed the clothes, undergarments, washed, not washed, she's bathed, or she's passed urine, passed stools, she's vomited, everything has to be noted down. General physical examination of the patient has to be noted down. We have to note down the height, weight, height in centimeters, weight in kgs, the build of the patient, how the survivor walks, her pulse rate, her blood pressure, temperature, respiratory rate, pulse, and any other deformities or disabilities. Injury, examination of the injuries in the body can vary from complete to absent of injury also. So here, where is the injury? what type of injury it was and what size, how was the injury. Where means we'll have to find out if the injury was in the scalp, face, neck, shoulder. Where is the injury? We'll have to see what type of injuries are bruises, nail abrasion, teeth bites, cuts, laceration, has to be fractures, tenderness, boils, or burns. How big the injuries are, size, shape of the injury, color, swelling, signs of healing. If it is healing, simple or grievous, and the dimensions have to be noted down. Examination, external genitalia, record the findings. So we'll have to find out, we have to see perspeculaum findings and PV finding if performed. So we'll have to first ask them if it can be performed, and then it can be performed. We'll have to explain them the reason for performing the perspeculaum and pervaginal examination. We'll have to note down everything, including the labia majora, minora, urethral meatus and vestibule, fourchette and introitus, perineum and hymen. Hymen are all to be examined. Pervaginal and perspeculaum examination should not be done unless required for detection of injuries or for medical treatment. It should not be done if it is not at all necessary. We'll have to check the anus and rectum if there is any bleeding, tear, vaginal discharge, and oral cavity also. Then our systemic examination are to be done. Evidence collection and sample collection to obtain confirmation of the allegation. This is done to obtain the confirmation of allegation, to establish the link between the victim and the scene, to establish the link between the victim and the assaultant. Every contact leaves us a trace, gives us a trace. Evidence collection and sample collection are always maintain the chain of evidence. We should always keep it in a format. It is important to identify the specimen, label the specimen, and sign the label. Immediately, once we collect the specimen, we have to name it, label it, and keep it. Record the disposal of specimen also. Sample collection and investigations. Hospital laboratory or clinical laboratory, you have to do for all blood investigations for HIV. All serology has to be done. Urine test for pregnancy, ultrasound for pregnancy or internal injuries, X-ray for any injury. Then central or state forensic laboratory, we have to debris collection paper and clothing, evidence where if available, to be packed in a separate paper after air dry. It should be air dried. Swabs from the stains on the body. Sample collection are to be done from the body, from the blood, serum, or any foreign scalpel hair. About 10 to 15 strands have to be given. Head hair combing, nail scrapings, both hands separately need to be taken. Oral swab, blood for grouping, testing the testing for drug alcohols, blood for DNA analysis, urine drug testing, any other tampon like sanitary pads, condoms, all to be collected. If not collected, we have to give a proper reason why it is all not collected. Genitalia and anal evidence, each sample to be packed and sealed and labeled separately to be placed in the bag. We have to pack everything in a separate bag and keep it safely. Matted pubic hair to be kept. If we have to mention if it is shaved or it is cut, how we have collected it. We have to take all swabs from the vagina and vulva and anal region for semen and DNA. Vaginal smear or to be air dried. Urethral swab to be taken. All these swabs to be handled properly, to be labeled and to be handed over to the police along with the attestation. Provisional and medical opinion. We have to give a provisional opinion that I have mentioned that so and so reporting with such type of sexual evidence with number of hours, how many hours or days after the instance she has reported to us. And we have to say my findings as follows, and sample collected, how much samples we have collected for the forensic evidence and for the laboratory. We have to label them, we have to name them, and we have to give them. All the clinical findings and additional observation are to be noted down and submitted. Treatment prescribed are that STIs, prevention treatment should be done, emergency contraceptions to be done, wound treatment, if there is any external wound, tetanus prophylaxis to be given, hepatitis vaccination to be done, post-exposure prophylaxis for HIV, counseling and others to be done. Date and time of completion of examination are to be noted down. We have to, once we have completed with all the examination, we have to write down the date when we have completed. The report contains so many number of papers and it should be documented everything and should be submitted. Final opinion. So our final opinion should be based on these conditions. When there is any recent injury to the genitalis or anus or the oral, all these how we find it is recent means then if there is any injury to the parts of the body, recent injury or any motile spermatozoas are recovered from these places, then we say it as recent sexual intercourse. If there is if the injury is healed or there is non-motile spermatozoas in the vagina when reported late, then it becomes remote intercourse. Local or recent injury to the genitalis, but no spermatozoas are recovered, then condoms or vasectomies or finger are the objects that has been used. Then recent penetration. According to this, we'll have to give if it is whether recent penetration or it was a remote penetration. We'll have to give in which place it has to be given in the final report. That is when the local partially healed injuries, there is no spermatozoa, then there is no evidence of remote penetration. There is nothing, then we say it as no remote, there is evidence of remote. Then there is, if there is any recent injuries or bite marks, etc. on the face, cheeks, necks, breast, nipples, thighs, or etc. But injury to the genitalia are absent, will help arrives before actual penetration occurs. Whereas evidence of recent sexual assault. This is this is evidence of recent sexual assault. Partially healed wounds in all these places, then it becomes remote. This is how we examine every part and we have to report to them. Findings in support of the above opinion is to be taken into account the history, clinical examination findings, and laboratory report of the bearing of the so and so bearing the identification mark described above. With so many hours after the instance of sexual violence, I have the opinion of what is your opinion. Based on those things, we'll have to give the opinion based on those things. If it was a recent one or a remote one, and where did we find our evidence? So we have to write down and we have to give our opinion. Signature of the examining doctor has to be there at the time and place, name and signature. And very important thing is that a copy of the entire medical report, whatever we do, has to be given to the survivor. We'll have to give it to them with a free of cost. It has to be given immediately. Once we are done with it, when everything is ready, we have to give it to the survivor. Hence, summary, most important thing is informed consent, vaginal examination, 2-finger test not to be done, hymen or size of the vagina, etc. to be commented. Injury documentation is very important, sample collection to be done, and final opinion to be given after that. The following are the components of comprehensive healthcare response to the sexual violence and must be carried out in all cases. First is your consent, then the first aid to be given, and history is very important, and examination. In examination, we have to do age estimation is very important. Physically, dentally, and radiologically, age can be estimated. And examination, and then comes the important is the evidence collection. Evidence should be collected. It should all be dry packed and sealed, and then it should be handed over to the police. All the evidence should be documented. We have to document and write. And then continuation of that is we have to treat the patient. Treat means if there is any injury, we have to treat. STIs, test and treat the prophylaxis. HIV need to be tested and to be treated. Emergency contraceptives to be given. Counseling, information and referral to other services to be done, and then discharge and follow up the patient. Sexual assault and forensic examination kit. So these are all kits which we need to have always. So equipments of examination table, we need a torch for prophylaxis or treatment of sexually transmitted infection as per the country protocol of syndromic cases management, antibiotic. Consent form to be documented. Scissors are to be there, nail cutters, combs, measuring tape, all these are to be available. Sterile gauze, swabs, containing containers for transport of the swabs, microscope slides, vacuometers for collection of blood samples, sterile urine specimen containers are to be there, sheets of paper, then paper bags, plastic specimen bags are to be get, spatula, sterile surgical gloves, mask, cleaning materials, antiseptic solutions, perineal sheets, gown, all to be available, sanitary napkins, speculum, proctoscope or anoscope to be available. All these are to be available. Thank you. Registration and pre-test and post-test and feedback is a must. Certificate will be awarded to the participants on the course, attendance, and submission of the registration, pre-test and post-test feedback. Thank you.
Thank you so much, Gayatri. Sorry, Akila, for walking us through this difficult topic, but a very important one, and you did a very good job. Thank you so much. I have posted in the chat box 2 links. The first link was related to the phone numbers, and the second link is to the last presentation which Akila has made. So please click on it and you can download this or save it somewhere so you can download it for later this thing. And the last link which has been posted just now by our colleague Sriman is related to the post-test and the feedback. Click on this link and you will be taken to, it will open a window which will allow you to submit the post-test and feedback. If you can't submit the post-test and feedback right now, copy this link and save it somewhere so that you can go and submit it later. Normally, it takes about anywhere between 5 to 7 minutes to submit them. With that, thank you very much each and everyone for having joined in today. And a special thank you to all the speakers and the faculty, which includes, the recent ones, which is Akila and Gayatri, who spoke earlier. We had our colleagues who also spoke earlier, which includes Kavita and Prema Priya and Lakshmi as well. If there are no further questions, we can call it a day, and each one of you have a wonderful evening and a good weekend to look forward to. We will keep you posted on the next steps, and so that how we can see how we can involve you all also in similar kind of trainings. So with that, all the very best and take care.
Thank you, sir. Thank you to all faculty.
Thank you.